Good afternoon. Today we'll be discussing vulvovaginal candidiasis. I'm Kashifa Jafta and I was supervised by Dr. Bhatt for this discussion. Vulvovaginal candidiasis, which for all intents and purposes during this talk will be referred to as VVC, is an infection of the vulva and or vagina characterized by inflammation in the setting of a Candida species. VVC is the second commonest vaginal infection after bacterial vaginosis and accounts for 1/3 of vaginitis cases. The most common causative pathogen is Candida albicans. The second commonest organism is Candida glabrata, which is indigenous to the GIT and the skin. Candida albicans is also considered part of normal vaginal flora in most healthy women. Most often, the clinical diagnosis is made based on the symptoms and not confirmed by microscopy or culture. Accurate epidemiological studies are difficult to perform due to widespread use of over-the-counter antifungal agents. The prevalence of VVC is highest amongst women of reproductive age. 70 to 75% of women report having at least one episode within their lifetime, with 40 to 50% experiencing recurrence. Of those, 55% report having had at least one healthcare provider diagnosed and treated episode before the age of 25. 29 to 49% of premenopausal women report one lifetime episode, and 9% report having 4 or more episodes in a 12-month period, which is also known as recurrent vulvovaginal candidiasis. The incidence of a single or sporadic infection increases with age up to menopause. VVC is uncommon in postmenopausal women unless they are on high estrogen therapy or in prepubertal females. Candida albicans is a fungus characterized by yeasts and pseudohyphae, which is the commonest causative pathogen in 80 to 92% of cases, the rest of the cases most likely being caused by Candida glabrata. Disturbances in the vaginal microbiological ecosystem or disturbances of normal vaginal flora result in overgrowth of the organism, which then colonize the vulvovaginal mucosa by penetrating the superficial epithelial cells, and this results in a symptomatic episode of VVC. This mechanism that transforms an asymptomatic colonization to an invasive form resulting in inflammation is a complex and unknown one. Pathogenic organisms that have two forms of development, as in Candida, the two forms are plankton and biofilm. A biofilm is defined as a community of microorganisms attached to a surface and encompassed by an extracellular matrix. This biofilm then gives these microorganisms a greater resistance to antifungal agents. Sporadic or acute attacks of VVC often occur in isolation or without an unidentifiable precipitant. However, there are a number of predisposing factors for symptomatic infection, namely diabetes mellitus. VVC is more common in patients who have poorly controlled diabetes. Candida glabrata has also been shown to be more associated in type 2 poorly controlled diabetics. Immunosuppression is also a common risk factor for VVC. Immunosuppression in patients who are HIV infected has been shown to be associated with an increased frequency, persistence, and recurrence of symptoms, however, not associated with severity of the condition. Certain drugs which cause immunosuppression, examples are glucocorticoids, antimetabolites, or patients who are on chemotherapeutic drugs, could also be at higher risk of developing VVC. Antibiotic use or broad spectrum antibiotic use is a common risk factor for VVC. There have been studies with weak evidence to suggest that the use of a lactobacilli containing probiotic could prevent this. However, there's no evidence to suggest it. Iron deficiency anemia is associated with VVC as well, as iron deficiency anemia determines the balance between and the intensity of a type 1 and a type 2 immune response. A type 2 immune response results in recurrence of candidiasis or promotes the recurrence of candidiasis. And iron deficiency anemia, which has been linked to the production of interleukin 4, has been shown to promote a type 2 immune response. Conditions with higher estrogen levels, examples like pregnancy and postmenopausal women who are using high estrogen therapy, could as well be at risk of VVC. Combined oral contraceptives with an increased dosage of estrogen could result in VVC. Contraceptive devices in the form of vaginal sponges, diaphragms, or even IUCDs have been shown to have an association with a candidal episode. However, studies suggest that it is due to certain species of Candida with the ability to form a biofilm on the IUCD and not the intrinsic quality of the IUCD itself. Certain sexual behaviors, especially resulting in vaginal or perianal trauma, could result in a contamination of the candidal microorganism. Certain hygienic properties could result in VVC, namely swimming in a chlorinated pool, the use of vaginal douches, certain intimate body washes, and certain scented panty liners could result in a candidal overgrowth as well. There's weak evidence to suggest that tight or non-breathable or synthetic fabric clothing could result in VVC. Symptoms that patients complain of, the most common being vulval pruritus or itching, as well as vaginal discharge. The description of the discharge is usually a white, thick cottage cheese or curd-like discharge, and most of the time it is odorless. This then results in burning, irritation, and soreness, most likely due to the itching and scratching, which then further results in dysuria and dyspareunia. Upon the examination of the patient, erythema of the vulva and vaginal mucosa is noted, with vulval edema, and in severe cases due to itching and scratching and ulceration could result in excoriations and fissures. White plaque formation on the vaginal walls could also be noted on speculum examination. The cervix is most likely spared, appearing macroscopically normal, and the patient should not experience cervical excitation, tenderness upon examination. The diagnosis is usually made upon history and the office evaluation. The office evaluation includes the clinical examination we just discussed, including the speculum exam. When doing the speculum exam or the clinical examination, a vaginal pH should be taken. Most patients who have a candidal episode or a VVC episode have a normal pH, which is between 4 and 4.5, as it is not associated with a disturbance in the lactobacilli. If the pH is higher than normal, one should suspect a bacterial vaginosis or trichomoniasis. One can also then obtain a sample for the wet mount smear and microscopy. HIV testing should be offered. As previously discussed, HIV positive individuals have a risk of increased frequency, increased persistence, or recurrence of symptoms, however, not increase in the severity. Once a sample is obtained, a wet mount smear can be prepared by adding 10% of potassium hydroxide. This eliminates cellular components, making it easier for one to see the budding yeast, the pseudohyphae or hyphae. A Swans-Lambkin's fungal stain can also be added, which is potassium hydroxide with surfactant and a blue dye, which will then cause blue staining of the candidal species, making it easier to see under a microscope. Culture is not routinely done or recommended and is reserved for patients who have a history, who have symptoms suggesting a VVC, but have no visible pathogens under a microscope on the wet mount smear. It is also recommended to be used in patients with persistent or recurrent symptoms. Recurrent vulvovaginal candidiasis, or RVVC, is defined as 4 or more episodes of symptomatic acute VVC in a 12-month period. 30 to 50% of RVVC cases have no identifiable etiology or predisposing factor, i.e., it should not be caused by recurrent use of broad-spectrum antibiotics or in a poorly controlled diabetic. When this relapse occurs or poor response to a azole treatment is noted, infection possibly could be caused by a new strain of Candida albicans or an azole-resistant Candida albicans, or a non-albican candidal infection like Candida glabrata. And as a result of the interaction with this microorganism with the vaginal epithelial cells and the ineffective immune response to its presence, which is the possible biofilm formation, RVVC can now be considered a chronic condition which will require prolonged suppressive treatment to achieve symptom relief or resolution of the condition. The treatment is indicated for symptomatic women. 10 to 20% of some may be asymptomatic, especially in patients who have a repeat positive culture. So no clear benefit has been established in treating a partner, as traditionally VVC is not been noted to be a sexually transmitted condition, given that it is caused by an organism that is part of the normal vaginal flora. Treatment regimens can be based on an uncomplicated or a complicated type of infection. There are multiple varieties of oral and topical agents available over the counter, and in randomized controlled trials, both oral and topical agents have achieved comparable clinical cure rates of more than 90%, and therefore other considerations should be taken into account, as in the patient preference. Is it easier for them to use an oral agent versus using a topical agent? The side effect profiles, which in both application methods have been shown to be minimal, contraindication, and the cost of the prescribed treatment. So the classification of candidal vaginitis will allude to the treatment, and uncomplicated disease, all of the 4 parameters are required. So mild or moderate symptoms, it's a sporadic or acute infection. You suspect that it might be just a candidal albican and not a different strain. And when they say a normal host, it implies that the patient does not have any other predisposing factors that could result in the condition. So uncomplicated vulvovaginal candidiasis should be treated with single dose oral fluconazole of 150 milligrams. After you have given this to your patient, you need to remind them that it will only take effect within 48 hours, and in that time you can prescribe a topical corticosteroid to provide relief until the oral fluconazole takes effect. Within 14 days, 90% of patients have had symptomatic relief. In HIV positive patients, fluconazole 150 milligrams of 2 to 3 doses taken 72 hours apart can be given. If the patient opts for topical fluconazole, it should be given for 14 days. Other treatments that have been suggested are behavioral adjustments, as in glycemic control, changing the IUCD, using a different body wash or different intimate wash, etc. There have been discussion around the use of probiotics either after an antibiotic has been used or during the use of an antibiotic. However, there's very weak evidence to suggest that any probiotic containing lactobacilli might improve the outcome of using a broad spectrum antibiotic. Dietary suggestions have been with regards to garlic or yogurt containing live cultures, either taken orally or with vaginal administration. However, both have not been proven to prevent vulvovaginal candidiasis or to treat it. Treatment of a complicated vaginal candidiasis, so either a severe vaginitis symptoms, however, just the first episode, can be treated the same way an HIV positive patient could be treated. So oral fluconazole 150 milligrams every 72 hours, which means day 1, day 4, and day 7. 3 doses, depending on the severity, which can also be given in topical form for 7 to 14 days. With recurrent vulvovaginal candidiasis, the treatment is slightly different. The patient will require an induction treatment and maintenance treatment. Induction treatment is exactly the same as for severe vaginitis symptoms, so it's 150 milligrams every 72 hours, day 1, day 4, and day 7, for 3 doses, followed by maintenance treatment of 150 milligrams of fluconazole weekly for up to 6 months. 50% of patients with recurrent vulvovaginal candidiasis might have a relapse. If a relapse occurs, the treatment period should be extended for up to 1 year. Compliance should be discussed with the patient, and if 1 or 2 weeks were missed, you can keep the treatment up to 6 months. However, the induction treatment should be offered again. In pregnancy is a high estrogen state, thus it could result in frequent episodes of VVC. However, VVC in pregnancy is not associated with adverse outcomes, and there's no correlation shown between an episode of VVC and preterm labor. Oral azole therapy is avoided due to an increased risk of miscarriage. Studies suggest that it increases the risk of miscarriage up to 3-fold if fluconazole is used in the first trimester. Certain fetal abnormalities have been described in patients who have used high doses of fluconazole in the first trimester, so 200 to 400 milligrams or more, and more frequently, and it could result in cardiac, musculoskeletal abnormalities or cleft palate or cleft lip abnormalities. Thank you.